The first case I'm going to present is a patient that I dealt with who had arm ischemia in the setting of subarachnoid hemorrhage. So this was a gentleman in his early 50s who had multiple health issues as well, who presented with severe headache and neurologic changes, was found to have a subarachnoid hemorrhage and hydrocephalus based on this. He had 2 aneurysms, which they thought were responsible. He had A-lines placed on both sides for monitoring of pressure and was on norepinephrine to maintain hypertension and perfusion of his brains. The left brachial A-line was removed. His hand remained severely symptomatic. It was actually ischemic after the introduction of the A-line itself, likely related to vasospasm around the A-line, but obviously something more had happened. He had diminished motor function and clearly had diminished flow. We'd gotten a duplex that had shown occlusion of his brachial artery, probably in my view with thrombotic debris from the A-line placement. Over the next few hours, we were really not able to give him anything more than just a low dose of heparin. We put him on 500 units an hour. It really did not help anything in the arm itself. There were no signals in the radial artery. There were, by duplex, some antegrade flow in the ulnar artery, although barely, and there was no obstruction above that brachial artery thrombus. With his arm getting worsened, the neurosurgeons were actually concerned about the potential for rebleeding and for vasospasm, so they took him back to the OR to do an angiogram, did the angiography, and at the time that they did that, we did an angiogram of the left upper extremity. Again, we just used local anticoagulation rather than systemic anticoagulation and utilized this device in the upper extremity. So these are the pre-procedure images. On the top, you can see that the axillary artery, and you begin to see some abnormality in the mid-brachial artery. On the right there, you'll see that there clearly was significant impairment of flow and essentially sitting thrombus within the blood vessel. This was actually fairly easy to cross with the device, and a single pass with the device brought back some debris. And you can see on these completion images, there's good filling now through the entirety of the brachial artery and filling into a spasmed radial artery and a widely patent ulnar artery as well. I actually saw this patient recently in follow-up. He's now got a palpable radial and ulnar pulse normal function of his hand. He did remarkably well, was able to be anticoagulated after another several days. His sensation and motor function rapidly improved and he recovered without any sequelae. I put this up because this was actually debris from the first time I used this device. It was another neurosurgical case where they had used a femoral approach, developed ischemia on the ipsilateral side. Imaging with CTA showed debris within the popliteal artery. I thought it was an embolus from their closure device. Passed this device from the other side, and this was the debris I brought back. And it convinced me that there were very few devices that would be able to remove this type of material from an artery. And particularly when I think about emboli that come from the heart, they're very difficult to retrieve with anything other than a catheter that has something to drag the device or the debris back into a sheath, or in surgical situations to bring it out through the arteriotomy that we've created. This sort of convinced me, and this debris that I pulled back from that same case, that this was very different than anything I'd used before in dealing with patients who have acute limb ischemia, and particularly in patients with embolic debris.